Hello, my name is Lukla Biasi. I'm a vascular consultant at Guy's and St Thomas's Hospital in London, a large tertiary referral center for complex lower limb revascularization. Many thanks to the Leg Club Foundation for the opportunity of sharing with you this presentation on the state-of-the-art of lower limb surgery and the indication for specialist referral for leg ulcers. Leg ulcers may have multifactorial etiology, and sometimes the differential diagnosis may be extremely complex. However, the reality is that the vast majority of leg ulcers have either a venous or arterial component. Venous insufficiency is by far the most common underlying reason of leg ulceration, comprising for approximately 2/3 of the chronic leg ulcers. However, peripheral arterial disease and diabetic foot conditions represent the most threatening etiology, exposing to the risk of limb loss, sepsis, and ultimately death. Peripheral arterial disease may present with a wide spectrum of signs and symptoms. However, we refer to chronic limb-threatening ischemia, CLTI, or critical limb ischemia, CLI, in the presence of ischemic rest pain and tissue loss. CLI or CLTI is a limb and life-threatening condition that requires timely revascularization to preserve the viability of the leg and to save a patient's life. It is paramount to differentiate between critical limb ischemia and non-critical peripheral arterial disease, i.e. intermittent claudication. Intermittent claudication and CLI are two completely different conditions with a different natural history and different outcomes. Intermittent claudication, highlighted in yellow, is a relatively benign condition with only a small risk of deterioration, approximately 5% yearly risk of progression towards CLI. On the contrary, critical limb ischemia is a life and limb-threatening condition. At 1 year, more than half of the patients presenting with CLI are either dead or have lost their leg. Interestingly, the main reasons for mortality are non-leg related, and I refer to strokes or acute coronary events. Arterial foot and leg ulceration requires a timely diagnosis and treatment. However, these ulcers are often complex to heal. Reason being they are multifactorial. This classification from the American Vascular Society comprise of 3 descriptive elements: the features and size of the wound itself, the ischemic component, and the infection. The acronym is Y5. Each of the three elements of the Y5 classification are graded from 0 to 3 according to the uh, extension and gravity of the presentation. When it comes to the assessment of the degree of ischemia, it is paramount to measure the perfusion of the lower limb, either with ABPI, occlusive ankle pressures, or specifically in patients with tibial artery wall calcifications, the toe pressure measurement. Arterial calcification are to be expected in patients with a chronic kidney disease or diabetes. It is very important also to assess the degree of infection, whether it is localized or systemic, whether it is affecting only the soft tissue or the bones, i.e. osteomyelitis. This is a key element in determining the degree of urgency and eventually whether to blue light the patient to the emergency department. The Y5 clinical stratification is a consensus classification that helps the assessment and the prognosis of arterial leg ulcers and diabetic foot condition. However, in real-world practice, even the most accurate and sophisticated classification may have flaws. It is therefore important to focus on a patient-centered diagnosis and treatment. Classifications may be misleading and they may not narrow down to the case-specific condition. I therefore strongly recommend to focus on your patient individually and never to generalize. These are examples of venous leg ulcers. Again, the spectrum may vary from a quite a benign chronic venous insufficiency to a unsalvageable venous gangrene and phlegmasia. Similarly, even foot condition and arterial ulceration may vary from relatively benign pressure-related ulceration, like the first on the left is a pressure plantar ulcer in the context of a chronic Charcot foot, to limb-threatening heel ulcer or gas gangrenous foot ulceration with no limb salvaging options. Time is the essence, or as we say, time is a tissue, meaning that every second, every minute counts between limb salvage or major limb loss, life or death. And on these premises, the Vascular Society of Great Britain has developed a clinical pathway for the treatment of peripheral arterial disease and specifically critical limb ischemia. The premise being that in the UK, approximately 23,000 lower limb salvaging procedures are performed every year. There is, however, a sort of a postcode lottery, meaning an inconsistent delivery of care according to the geographical area. The situation is then also aggravated by the concept of centralization of complex vascular procedure, meaning that all the arterial surgery within the vascular network is centralized in the big hospital, in the hubs. For example, Guy's and St. Thomas's have the largest vascular network comprising approximately 3.5 to over 4 million population catchment area, meaning that the amount of arterial leg ulcers and potentially limb-threatening conditions are overwhelming. The ambitious targets proposed by the vascular societies are that all patients admitted in hospital with a critical limb ischemia should undergo vascular intervention within 5 days from the admission. Patients with critical limb ischemia that are worked up as outpatients should be offered intervention within 2 weeks from the original referral, meaning that the clock starts at the time of the GP referral. This highlights the importance of a timely assessment and diagnosis in the primary care, either by the GP practice nurses or the community services. The reality is that the vascular pathways are extremely complex, and there is a huge struggle to reach the targets, the 1 week and the 2 week targets as proposed by the Vascular Society. I'm proud to say that at Guy's and Thomas's we have implemented a very efficient referral system via an electronic refer a patient software that allows not only to refer directly from the spoke hospital to the hub, but also open a line for GP to refer the emergent cases to our EVC, Emergency Vascular Clinic. This system allows the assessment and the treatment within the proposed targets. And here is where your referral will end up to. We have an excellent multidisciplinary team and a very nice view to boost our patients' morale. In conclusion, when it comes to the vetting of the referrals, we usually stratify the time frame and the emergency in routine referrals comprising varicose vein or intermittent claudication, soon, meaning between 6 and 8 weeks, for uncomplicated venous leg ulcer or complicated varicose vein condition like varicose bleeding or borderline peripheral arterial disease when There are not clear limb-threatening condition, but for example, occasional nighttime pain or cramps. Urgent referrals that we try to address within a fortnight, patients that have ischemic rest pain or arterial leg ulcer, i.e. critical limb ischemia or chronic limb-threatening ischemia, or emergency referral like diabetic foot infection and ulceration, for which we have developed a multidisciplinary diabetic foot clinic where patients should be seen ideally within 1 week from the referral. Unfortunately, sometimes it is too late, either due to the degree of infection, extensive tissue loss, or acute ischemia with mottling and acute neurological irreversible impairment. Finally, there are conditions that are often misdiagnosed or underestimated, such as groin abscess or infected pseudoaneurysms. This can be the result of a complication from a recent surgery or the sequelae of injecting drugs in the groin. Abscess and pseudoaneurysm needs to be addressed immediately. Hence, the patient should be blue lighted to the nearest vascular center. Often requires complex vascular intervention, such as a vein interposition graft, or in the case of an infected pseudoaneurysm, secondary to injecting drug. Often the main artery is ligated, possibly leading to a subsequent major amputation. Overall, the lesson learned is that even when dealing with lower limb condition, it is paramount a thorough physical examination, not just limited to the lower extremity, but including the abdomen, the groins, and the lower limbs in their totality. Thank you for your attention.